We continue here in this lecture series of airway management, an introductory lecture series in airway management. As a reminder, is basically my name is Felipe Urdaneta, and I'm going to be talking today about a something that interests me tremendously, which happens to be extubation period. If you think about it, for the past century or even more so than that, we've been concentrated on methods of intubation and concerning about problems associated with intubation and airway guidelines and all that. The problem is that we basically overlooked and have basically dwarfed in terms of importance the period of extubation. I'm here to point out to you that numerically speaking, problems perhaps occur less often at extubation, but when they occur, they're severe and can be severe and can lead to high degree of mortality. So we want to basically be spending more attention, and now that we basically have more methods of intubating successfully, we need to start paying attention to extubation as an equally important period of airway management. We've had, for lack of a better term, kind of a Copernican approach. We've always thought that basically the sun moves around the earth when it's the opposite. In other words, we've had importance thinking that intubation is the most important, but now we're noticing that extubation is equally as important. I bring this up because I have an interest in altitude, high altitude, but just I'm not never done it, but I have an interest in it. This is a wonderful picture of Everest. And same as basically you can have problems on ascending Everest, you can also have problems descending Everest. And you have not considered that you've climbed Everest successfully until you basically come down. Well, the same thing with airway management. If you have not planned for an adequate extubation, if you have not made and conducted an adequate plan, then you have not managed the airway successfully. When I get phone calls at night from my residents and they tell me, well, I'm going to intubate this and that, or this way or that way, or awake, or whatever that is, but they do not make plans about extubation, then I consider that they have not given me an adequate airway management plan. To illustrate the problems, we're going to basically present a case. The case, you're on call and you happen to be of part of the airway response team, in which you basically provide expertise and response in case there's airway emergencies. And this particular patient was a 36-year-old that had major trauma and was admitted to the hospital a couple of days before. He was extubated 48 hours and now ago, and now has suffered clinical deterioration, for which the team wants to take him to the CT scanner. Keep that case in mind. And one of the problems is that we tend to not to think about extubation until a major problem happens. Now, I'm going to be focusing on major problems. I'm not going to be focusing on transient or slight tachycardia or hypertension that happens upon extubation, or coughing or bucking, even though those are very important, specifically for certain procedures. I'm going to be talking about major complications about airway management, those that basically land you in the medical legal arena and perhaps bring you as part of contributing to the closed claims analysis. That's what I'm going to be focusing here today. And the take-home message here is that we need to pay more attention to this period of extubation. Comparatively speaking, perhaps numerically, the chances of having airway problems are less compared to intubation, but the consequences associated with extubation can be as lethal as the ones when we have problems at intubation. You can see in this slide that the incidence of complications is far less in the surgical anesthesia context compared to the ICU context, and that's naturally because the patients are completely different. But keep in mind, therefore, that a lot of problems can be associated at the problem of extubation. In the two databases, the majors that exist, the ASA and the Difficult Airway Guidelines, or NAP4, the incidence of problems associated, major problems associated like extubation, were 17 and 18% at in the ASA, and up to 29% at the DAS guidelines. So that can actually give you an idea. The problem is when your patients make it to the databases, and specifically when problems appear in the closed claims analysis, is due to mortality. And so the problems associated with extubation are low numbers but high impact. The mortality associated with extubation problems in the closed claims analysis is up to 94%. And if you, for example, have respiratory failure in the ICU post-extubation, the mortality of that patient, not related to extubation per se, but due to the severity of the disease of the patient, can reach up to almost greater than 50% of the time. So something to keep in mind. One of the difficulties is that we have variable timing of the presentation of these problems and ill consequences. We consider that things can happen early or late, and basically we consider early in the first 24 hours about extubation and late after the 24 hours up to 72 hours. In our particular case that I presented was a trauma patient that was in the first 48 hours post-extubation. Usually problems occurred in the first 24 hours, usually in the first 2 hours, and if not, in the first 24 hours about extubation. But you can see there's a lot of variability here. To give you an idea of the issue of extubation and the lack of importance, or not importance, but lack of mention in the guidelines, even though it was mentioned originally in 1993 in the first version of the airway management guidelines, it took 19 years until the first guidelines of extubation were published by the Great Britain by the Difficult Airway Society. 19-year gap before guidelines were actually published in terms of airway management. And what they basically say is that the most important thing is that we need to develop a strategy. So remember, I already talked about this in the periodic table of airway management. A strategium is the most important. Well, the same thing here, we need to develop a strategy. What the British say is that you need to develop a plan. You can follow it here. Of course, you can read about them. You can then follow a procedure. The procedure for extubation is not technically challenging. You basically take the tape out or whatever means of securing the tape, and you basically deflate the cuff in case the cuff is up, and you take the tube out. And then most importantly is you need to actually have a plan for after when you take the tube out is what's going to be the disposition of the patient, how are you going to sign out the patient, what kind of oxygen you're going to deliver, etc. afterwards. I particularly like the way the Canadians do it. The Canadians have a mnemonic that's called reverse, in which basically they consider extubation not just the end point of the procedure itself, rather the middle point. You need to be doing 3 things ahead of time and 3 things afterwards. And those things is obviously assure that the patient's reversal is adequate. And I'm just going to go real quickly, of course, that you have an adequate extubation plan, that you are ready to proceed in terms of adequate location, that you have means to reintubate in case things don't go well. Then you're basically going to develop a plan for recovery for that patient. Then you're basically going to have a safe transfer, and you have a extubation failure plan ready and available and handy. Think about this. Most of the time we're prepared for intubation, but for extubation is, do you have drugs ready? Do you have another tube ready? Is the same device that you use at intubation ready and handy? I've seen a lot of instances in which, for example, they intubated with a fancy device, and that fancy device gets taken away in the middle of the case to get it clean. And by the time of extubation, that fancy device is not available upon extubation. So that can lead to adverse consequences. One of the most important things that we do is to establish risk factors. And of course, some patients are more risky to extubate than others. Some cases are more risky to extubate than others. I'm not going to spend much time here, but needless to say, patients with obesity, with obstructive sleep apnea, patients that have neuromuscular diseases, for example, ALS or something, those are very difficult. Same thing as trauma patients, basically anything distortion of the anatomy or cervical spine problems, or patients that are prone for aspiration or that have been a difficult airway to begin with. your patient was a difficult intubation to begin with, well, obviously you have to consider that the extubation is going to be equally difficult because it's going to be more risky in case you did not plan accordingly or you did not time it adequately. So you always have to keep in mind that those patients are not straightforward to doing it. Going back to our patient is basically, remember what I told you, is 48 hours post extubation and now is clinically deteriorated and you are on call. That patient was transported to the CT scanner, but guess what device was forgotten in the unit and not brought with the patient that should have been brought with the patient. And when the patient reached the CT scanner, had a deterioration of this clinical status, and the patient could not be reintubated because the clippers that were meant to be next to the patient in case they needed to have an airway emergency because the patient had a cerclage were not available. So you can imagine how things can happen, and that's why I said that planning for extubation is equally as important. So that gives you an idea of the planning that needs to go on. So obviously, every time we talk about extubation, we need to talk about advanced options for extubation and use of exchange catheters. I'm not going to spend a whole lot of time because you'll be using them. Obviously, they can fail. They can create pneumothorax, especially in emergency circumstances that are not foolproof, but they're actually a great way of kind of providing a safety period in case your patient needs to be reintubated. Now, in the past, and I bring this up because I have it on this slide, there is a concept that you can basically ventilate through this exchange catheters. This is no longer recommended, even though the manufacturer still places those connections and all that. It's no longer recommended. There's a bunch of reports of adverse events, specifically pneumothorax and pneumomediastinum and death associated with this practice. So these are just basically meant to be temporary measures of in case you need to reintubate your patient or immediately to guide you in terms of how to provide safe extubation, but they're not meant to be providing insufflation or for ventilation, as some people call it. I'm not a fan of that, and like I said, there's a lot of problems associated with it. Not in North America, because it's not FDA approved. There is what's called the stage catheter, which is a combination of an exchange catheter and an epidural. The purpose is the same. Seems those people that have used it, specifically in Europe, which actually develop, it actually is a good way of actually doing it. It's not foolproof. Basically, it's well tolerated, but as you can imagine, it can also end up in the esophagus erroneously. Another method that we used to use specifically more or less a decade ago was the famous Bailey maneuver. And Bailey basically described the placement of a supraglottic device alongside an endotracheal tube so that basically you were able to extract the endotracheal tube, advance the supraglottic, and provide a bridge to extubation. And when he described it, he was able to say that it was able to decrease the respiratory events, basically improvement in terms of complications of airway management in the recovery period. I think it has fallen out of favor more or less because now, fortunately, we have newer methods of oxygenation that do not require it. I have done it. I have also failed on it, and I've had severe laryngospasm associated with it. But it's a good method in case you want to basically bridge your patient from full intubation to extubation and having an intermediate means of actually providing methods of ventilation and also as a conduit for reintubation in case the patient needs to be reintubated. And of course, leave it to the Canadians to do a combined technique in which they use a supraglottic device, a Bailey maneuver, but they also place a exchange catheter through it so that you have both of best of both worlds. You have a means to reintubate if you need to, but also using it combination with the supraglottic device. This is a patient of mine. This patient was a nephrectomy. He was 300 plus pounds and We did it successfully, but I thought it was a little bit cumbersome to do. Specifically, I did not know how long to leave the supraglottic device and how long to leave the exchange catheter, but it can be done. One of my preferred methods of guiding extubation is we're using ultra short acting opioid remifentanil. I think this is a very reliable and predictable way of extubating specifically difficult patients. I do it a lot on ENT, specifically on neck dissections, and prevent coughing, which can predispose to hematomas, etc. So I use it a lot, and I think it's a wonderful technique. It's not the only one, but it's a reliable technique. And as I alluded to, now fortunately we have other methods to safely conduct extubation and to provide some bridging of the patients immediately post-extubation with the use of traditional oxygen delivery methods, CPAP, nasal positive pressure ventilation, and high flow nasal oxygen. Those are actually have taken a lot of real estate, and we used it quite often, and they're a wonderful way and innocuous way of doing things. A little bit expensive, of course, but this area or this timing of extubation can be critical in a specific group of patients. So I want to leave you here today with a kind of philosophical approach. Hopefully you can read the articles that I recommended. Remember, you don't want to learn safety by an accident. You don't want to learn basically by an adverse event during extubation, and hopefully you don't do it. Think about this. When you're planning the airway, extubation is one of the steps as important as intubation, so you always have to plan how you're going to do it. You might, for example, consider that a plan might be, I'm not going to extubate. That's a plan. Your plan might be, I'm not going to extubate because I'm going to perform a tracheostomy during the case. That's a plan. Well, your plan might be, well, I'm going to extubate at the end of the case provided the patient is warm, muscle relaxants are administered, reversals, I'm sorry, free of opioids, the patient's breathing spontaneously, heart rate and blood pressure are adequate. That's a plan, and that's how you need to conduct this period of extubation. There's been a lot of problems associated with extubation, and when we face problems is when we don't pay enough attention. You have been warned. Hopefully your extubations are going to be smooth and you're not going to have any problems in this period of airway management. Thank you very much.